Public dialogue and civic engagement are important. They play a role in improving the health and well-being of Texans across our great state. That's why Blue Cross and Blue Shield of Texas is proud to support Texas Tribune events like the conversation you're about to see.
So, Chairman, let me begin by stepping back and asking a broad question about health care and this session. If I look back over the what's 140 minus a month, whatever it's been so far, I don't think of health care as at or near the top of the agenda of issues during the 84th session. Not that it shouldn't be, not that health care is not enormously important, not that it's not an enormous line item in the budget, but when we heard the governor in his inaugural address talk about what might be his priorities going forward, we heard the lieutenant governor talk about his priorities, nary a word about health care. In the State of the State, the governor talked about health care, but really around the edges. He didn't talk about the number of people without health insurance, didn't talk about health reform. He talked about things like mental health, women's health, residency slots, all important. Chairman CROWNOVER, you'd be forgiven for thinking that health care wasn't even really a big issue in play this session.
Well, is this on?
Yeah.
Yes. It's actually an enormous issue, and when I came in years and years ago, I remember people saying, we're going to have to be careful. Our health care is going to keep creeping up where it crowds out other things.
Right.
And I think we've just seen it creep and creep and creep, and I think that's...
we're kind of there.
We're kind of there. Yes,
right.
We are.
The standard line is that education has been the #1 line item in all funds budget forever, and that health care has risen to meet or come close to meeting education and may soon exceed it to become the #1 line item. That's pretty much where we are, right?
Kind of where we are.
Kind of where we are. So are we better off today than we were at the beginning of this session in terms of this issue? Have we worked towards some solutions to getting a handle on that problem?
Well, I think we've done some positive things.
Yeah.
Last session, we had a huge increase for mental health.
Right.
We have a mental health coordinator, so trying to make sure that our kind of silos are working better together.
Yep.
And the coordination there. We have had an increase in funding for women's health. But what we need to talk about is the outcomes, not just the increase in funding.
Right, not just the inputs.
So it's a hollow victory if we're just spending more and more money, but
right.
not getting better outcomes. And so when I had the surprise of being chairman of public health, I thought, oh my gosh, I am out of my league. And we decided as a committee that our theme was going to be Healthy Texas 2030.
Right.
That's a nice amount of time to think about achievable goals.
So building blocks towards some future outcome, but
right.
not necessarily all at once. We're going to solve the problems of the state right now.
And what drove me was thinking about a thing I read in the Wall Street Journal years ago, that we think of healthcare as being all these very dramatic, very expensive, very cutting-edge things. And actually what has changed the life expectancy for people in the United States is some very basic things. And this is in the last 100 years.
Right. Clean
water, sanitation, refrigeration, and simply penicillin. So I think we're looking for these huge steps, and we're forgetting the basics, and we're looking for other people to keep us healthy. But the two main drivers on health in the state of Texas at this time are tobacco and obesity. And those are things that people can control themselves.
There's a personal responsibility aspect
right.
of that. It's not the state. Chairman SCHWERTNER, you've been taking up this session with a whole bunch of issues not necessarily part of Health and Human Services. You've been a leader in the discussion about tax cuts. You've been a leader in the discussion about the affordability of higher education. But at the end of the day, this committee is your responsibility as chairman. Do you think we're focusing enough of our attention as a state this session on health care?
Well, Evan, it's nice to sit down with you one more time. Thank you.
And it is always nice to be with you.
Healthcare is a tremendous responsibility and obligation of the state of Texas. As I think you said, it is one of the largest components of our budget. It's $75 billion, all funds, out of a little more than $200 billion total state budget.
Right.
And so just from that standpoint, it is an issue that does have to be addressed and worked on each and every session. Beyond that, beyond just the fiscal issues, and again, healthcare is the fiscal issue of all state budgets, including also our federal budget.
Right.
But we're working also diligently regarding a number of sunset bills. Our health agencies have been under sunset review, and I'm very pleased to have served on the Sunset Commission.
Right.
And those bills, there were 20 sunset bills. A number of those, most of those actually are related to our health agencies. Those are working their way through the legislative process, and we got to make sure those health agencies are working as efficiently and effectively for the people of Texas that need those vital services provided by and regulated by those health agencies.
Well, and I know that you've been particularly active on the DFPS reform and sunset. I want to come to that in a little bit. I want to ask you, Chairman SCHWERTNER, though, about where we are on the larger topic. We'll get down to some of the smaller topics, but the large topic of health reform. We've been engaged in a conversation for the last number of years, occasioned by the Affordable Care Act coming online. Not every state, as you know, has been as eager to embrace it as every other, and we have not been particularly eager to embrace it as a state over the last couple of years. Some statistics came out last week, a study by the Episcopal Health Foundation and Rice University's Baker Institute that said that the rate of Texans without insurance, or the percentage of Texans without insurance since the Affordable Care Act came online, has actually fallen from 25% to 17%. They've said that the rate of drop among poorer Texans has been slower than the rate of drop among Texans with more income, but that overall we're seeing some progress despite the fact that the state hasn't been particularly eager to embrace that. Do you consider that to be a legitimate finding? And do you consider that to be good news? Or is the problem kind of solving itself or being solved whether or not we're participating? Chairman SCHWERTNER.
Well, I think that is a legitimate finding. Certainly when you throw $1 trillion nationwide at a problem, you're going to see some results, both positive results and negative results.
Right.
And we've seen changes in the private insurance market regarding individual policies. We've seen changes in employer-sponsored policies through the mandated essential health benefits, which have raised premiums. But on the flip side, through the utilization of these exchanges and subsidies, we've seen individuals that had pre-existing conditions that were unable to access care, and those with low income, 100% to 400% of the federal poverty level, being able to obtain health insurance, maybe sometimes for the first time. But the issue of the uninsured that you alluded to is an issue that the state that does need to be continually evaluated. But it's more than just a number or a group.
Right.
We have a very dynamic population here, and a number of individuals of that group are undocumented residents. And no expansion of Medicaid will ever, obviously, cover those individuals. We have individuals between jobs that are short-term regarding their uninsured status, but as a proportion of the uninsured, it's not insignificant. And we have individuals in that uninsured amount, that uncovered amount, that are above 400% of the federal poverty level and choose not to buy health insurance despite the mandate as proposed by the ACA. So it's much more complex than that, and Texas needs a different solution than just expansion of a entitlement that's been in a lot of ways been shown to be costly and unsustainable and really in a lot of ways broken. So
back on March 2nd, you were part of a press conference, you and Lieutenant Governor Patrick and others talking about this issue. The Senate has been really into press conferences this session. So on March 2nd, there was a press conference at which this topic was discussed. You talked about the fact that back in 1989, 12% of the budget was Medicaid. Now this year it's 29%. We've seen actually Medicaid occupy, to the theme we were talking about earlier, occupy a much larger percentage of
close to $60 billion, all funds.
Indeed, it's growing 2.5 times faster than any other part of the state budget. I mean, you talked about the growth, and you said at that time any expansion of Medicaid in Texas is simply not worth discussing. You haven't changed, I assume, 2 months later.
I've not changed, no. We need health reform that incentivizes the individual to take personal responsibility, and we need cost containment, we need cost sharing. We need sustainability from a cost standpoint as well. These are the elements of health system reform that will make it right for in my opinion, that individual, but also for the taxpayers and for the future Texans that are yet to be born.
Chairman Crownover, the study that I alluded to by the Episcopal Health Foundation and the Baker Institute found that while we've decreased the number of people or the percentage of people in our population who have no health insurance by 30%, states on average that were more willing to embrace the Affordable Care Act actually decreased their uninsured populations by 50% or more. So we were actually lagging in terms of our drop to state, compared to states that had embraced the Affordable Care Act. Does that give you any pause to think maybe we should have been a little bit more willing to look at the Affordable Care Act favorably?
Well, I've had numerous conversations with my congressman, and I think Medicaid, as we know it, is unsustainable. So I can't see us jumping on a bandwagon top into a program that is simply unsustainable. There is not enough money in the federal government. So we are trying to craft our own situation.
Right.
And one thing that people don't talk about nearly enough is the really wonderful organizations that are doing health care at the local level, the nonprofits. Denton has multiple groups that are doing just a yeoman's job of helping, and it's a more comprehensive look. I am so impressed with what they are doing. And oftentimes it's much more comprehensive. It looks at the whole person instead of somebody just having health insurance.
Does it give you some concern that the population is growing as quickly as it is? Think that somehow these off-book solutions can somehow solve the problem given the magnitude of the population growth in the state?
Well, I think these off-book actually do a better job. I've got my health savings account bill coming up today on the House floor.
Yeah.
And we have had long conversations. They talk about the Affordable Care Act being the comprehensive answer. I don't think that's the answer. I think insurance is the problem, not the answer. You could have good health insurance and have bad health care.
Right.
On the other hand, you can have no health insurance at all and have good health care. We know that, okay, so on a chart with the, it shows what Americans die of. And the first thing that Americans die of is tobacco. It's a huge, huge winner by far. But the interesting one was the second bar on the chart was medical errors. So we think that everyone's dying because they can't get enough health care, but many times people die because they did get health care. So it's kind of funny that way. No, that's not that I'm saying.
Not funny,
yes,
haha.
Not,
I get it.
not
right.
funny, haha. Right. Funny, tragic.
Yeah.
So there are a lot of things that we want to work in. We want our medical facilities to have better outcomes. We know that we are going to have, we can't keep spending more and more money on health care. When it starts crowding out shelter and food, we know we've got a problem. So we're going to have some common sense in here.
Chairman Schwertner, there was a couple of weeks ago, the federal government made a threat. I want to call it a veiled threat, but it wasn't veiled at all, in fact. It was a threat. The federal government said that the hospital waiver is coming back up for renewal, 5-year waiver, and I think the estimated value of this is about $29 billion over 5 years. And the government said to Texas, and not just to Texas, basically, if you're not interested in expanding Medicaid, we may or may not choose to renew this waiver. Does that give you any concern? What should the state's position on this be?
Well,
it's a lot of money.
I think what you're seeing there is administration unbridled. We have already, or the Supreme Court's already spoken to that regarding the use of coercion to mandate an expansion of really supposedly a state-run program.
Yeah.
The Roberts ruling, the Supreme Court ruling. So I believe that Texas has already spoken and has joined, or at least is supportive of the state of Florida's position, fighting back against the federal government.
I believe Governor Scott is suing. Is that right?
And that's correct.
Yeah.
And if that were to happen in Texas, and we will have to address this with the 1115 renewal, I believe there will be a discussion regarding just how far the federal government can tell a state regarding the provision and our implementation of a state-run health plan that's already been shown by the U.S. Supreme Court to not be able to be put forth by the use of coercion. So we'll see.
You encouraging Attorney General Paxton to sue?
I think we should stand tall and strong as a state regarding the need for greater flexibility, the need to take care of our citizens in the way that Texans and their elected officials believe is correct.
Yep.
Both those that need that service and, again, the taxpayers and future generations of Texans. So, yes, I think if it requires that, I believe General Paxton should do that, yes.
Chairman Crownover, the state of Texas has not been shy about suing the federal government over the last number of years. Let's be honest. This seems like a ready-made opportunity for us to go to court again if we want to. Would you encourage General Paxton to sue if it comes down to this threat over the waiver?
Well, what I would encourage is for the federal government to realize that the states are created for a real reason. They're supposed to be the incubators. They're supposed to be.
Right.
And I think we need to cut the coercive strings and let each of the 50 states come up with their best plan that works for their state. Each state is different.
Right.
And I think we're smart enough that we would learn from the states that are doing a great job, and we would learn in the states that weren't doing such a good job. And because I just think the direction from above has become very muddled.
And Chairman, that was the point of your press conference back in March. You and the Lieutenant Governor and others were asking for more flexibility for the federal government, right?
And I think a lot of people do not realize, besides the cost and what it does to the other critical needs of the state regarding infrastructure development and education, but it also, Medicaid expansion puts a strain on the safety net of health care that already exists for those aged and blind and disabled, pregnant women and children that are already on Medicaid. And so do we need to put more stress on that safety net by expanding it to a group of low-income adults? Is that the right policy move in regards to a healthcare system that is already strained to the point of, in some cases, breaking regarding those other populations?
Of course, you know, Chairman, Chairman plural, that the fact is that people without health insurance are being treated. And the uncompensated care costs in emergency rooms are passed along to all of us in the form of property tax.
That speaks to insurance doesn't necessarily mean access. And access is between the EMTALA regulations and our very robust system of LQHCs, county hospitals, health-related institutions. Texas needs that flexibility to design a system that utilizing components of those that are more appropriate than just an expansion of a large-scale, top-down, federal to the state bureaucratic entitlement.
So let me ask you about this. Let me pivot away from this, although it's related, and ask you about the state budget. You are a budget conferee, Chairman SCHWERTNER, chosen by.
I'm on the Senate side doing Article 2.
You will be one of 5 senators, and there are a total of 10 budget conferees selected by the Lieutenant Governor or the Speaker to help hash out differences between the Senate and the House budget. And while there are areas of the budgets that have big differences, border security is one, be hard to bridge, it'll be a big fight, you all don't seem all that far apart on health care. You and Sarah Davis, the House budget conferee, who are responsible for your areas of the budget, the stuff we're talking about today, the differences are not significant differences. Is that a correct perception?
We continue to work in a very cordial fashion. I have the utmost respect and a great working relationship with Representative Davis. We have challenges in each one of the agencies, and over the last week we've been in conference for many hours,
right,
trying to hash out those differences. It's a unique experience. Just to shed some light on it, it's Representative Davis and myself, and then there's a team of individuals from Lieutenant Governor's office and the chair's offices, staff, and then obviously LBB and agency staff that continue to really explore these issues in conference and try to do what's right for the people of Texas regarding each one of those proposals. It's a tough undertaking.
Of course, it's easier if you're not that far apart. And again, I don't like to do math, but if I'm looking at the numbers here, it looks to me like you're less than $1 billion apart.
That's true, but where that billion is and other areas is sometimes mask some significant differences.
Well, the two big differences that jump out to me are, one, the House appears to be funding Medicaid payments to doctors at the Medicare, 100% of Medicare rate. Senate has left it at about 65%. Is that right? That's one difference.
That's correct, and that's, again, going back to one of the provisions of the ACA was a bump in reimbursements or payment to primary care providers. But it only lasted 3 years, and so the state now is having to react to that regarding, do we continue that at whatever rate to a certain type of provider, all those providers? Do we give them a partial bump somewhere between Medicare and Medicaid? And try to find a way forward. It's added complexity, and in general, the ACA has added, in my opinion, costs and certainly confusion, complexity, and in the end, loss of confidence in our federal government to meet the challenges, the large challenges that face our nation, whether it's health care, or Social Security, or the infrastructure issues that face our country.
Chairman CROWNOVER, the fact is that one problem we've seen is that the number of doctors who take new Medicaid patients in Texas is going down. I think it's now we're down at 34% of doctors now take new Medicaid patients. One of the issues, if not the issue, is exactly the one we're talking about, which is the degree to which they are made whole in the payments to doctors. And so the House seems to be more in line with let's take that number up and possibly get around this. The Senate is not there along with the House. Are you supportive of the House's budget as far as this goes? 100%?
Absolutely.
Right?
No, I think you can't just ask. In the good old days, a doctor would treat somebody for a chicken or some eggs. So that's kind of taken the fun out of that. But they still need to be reimbursed. And the headaches, it's almost often not as much the reimbursement rate as the headaches that go along with the paperwork.
Right.
So that's quite a problem also.
Chairman SCHWERTNER, we seem to have a lot of money in this budget, more than we've ever had available to us. We're not spending all of it, but we do have enough money. In theory, we might be able to go a little higher than 65%. Do you think by the time the conference committee does its work, the number will be higher than what the Senate has got in right now? Or are you resolute about 65%?
That's one component of the budget, and there's other components. For instance, the Senate budget funded Medicaid cost growth over the next biennium, whereas the House did not.
House did not.
Yeah, medical inflation, increasing service utilization.
Right.
But going back to your concern, again, it goes back to the straining of the safety net and trying to make sure we have an adequate network of providers. But yet we have limited flexibility to redesign the entire system, to design a care model that's correct for the individuals that need that care and long-term sustainable.
Of course, the next biennium is going to be effectively for the period before, if there's a change in administration, we'll have a change in president in early 2017. We don't yet know if it's going to be Democrat or Republican. We don't yet know what the disposition of the new president will be toward what we have been living under for the last number of years. So really, for the next 2 years, are we just in a holding pattern as far as this goes? I mean, there may be a stomach to repeal or defund in Congress, but it's not a veto-proof majority. The president's not going to go along with that. We're basically at a standoff. So will Texas's position for the next 2 years be essentially to wait out the end of the administration, or is there anything we're going to try to do between now and then?
There's going to be a Supreme Court decision regarding state exchanges versus federal exchanges. King versus Burwell. So that's an important issue regarding the one portion of the ACA, which were the state exchanges and subsidies, and of course the other portion was just the kind of wholesale expansion of Medicaid at the state level. So that's one thing, and then Congress will continue to evaluate whether or not there needs to be changes. We've had 20 unilateral actions by the executive, by the president and the CMS regarding how the ACA has to be changed to even make it functional. So there will be changes. Change is constant.
Right. So just to come back to what we were talking about before I move on to the other aspect of the budget, you are not saying that the 65% of Medicare won't change. That may change in conference.
There's always possibilities of change in conference until the budget is passed. But it goes back to my concern of adding a whole new population, a whole new entitlement to otherwise productive, low-income adults, to a system that is historically designed for those that cannot take care of themselves, the aged, blind, pregnant women, children, and those with intellectual and developmental disabilities. Is that the right thing for that population, for one thing? What does it do to their vitality and sense of worth and industry? And is it right for the group that's already being served by Medicaid? Is it right for the taxpayers currently? And what does it do to us from a sustainable cost perspective long term?
Chairman Crownover, an area where there is even less material difference would be mental health. The mental health allotments and the budgets are, I know, an issue important to both of you. You all are almost entirely aligned on mental health funding, right? I mean, that's actually an area where, just like the 2013 session, the state really seems to be stepping up.
No, and I think it's an exciting time for mental health. I have seen a tremendous change. You know, if I talk with my local sheriff, he says, basically, he's at the mental health business.
Right,
the
county jails are the de facto psych wards in a lot of
I talk
places,
to my
right?
chief of police. He says that's kind of the tragedy of his business.
Right.
So last time we had that huge increase on emergency, and I've even talked to some of the people, so when somebody's in a crisis, you don't give them a telephone number and say to show up Monday morning. We actually have the ability now, and I've talked to some of the people that go out, that they go out to the site and help immediately when it's necessary. So I think we're really thinking a lot smarter on mental health than we have in years, and I think that's a great thing.
Yeah. Chairman, not significant differences, right?
No, mental health has been a top priority of mine, and I think this legislature, ever since the tragedies that we saw across our nation, Aurora, Colorado, and of course the terrible tragedy of the children dying in school, I think it brought it to focus.
Right.
But we did a lot of work and a lot of increased funding last session. We continue that work. There are a number of DISRIP projects regarding mental health that are, I'd like to continue to explore their overall outcomes this next interim regarding their successes.
Right.
And then mental health has been the reorganization of the Health and Human Services Commission, with moving of mental health from Department of State Health Services over to HHSC to kind of realign it under medical and mental health. One Health is, I think, a big issue that is in flux this session, that I think is actually a good move, getting mental health out of Department of State Health Services, having Department of State Health Services as a standalone entity.
Now, you have carried a bill, Senate Bill 239, successful to this point, and it had a number of things that it would do, but one that got a lot of attention in this area is that it would provide financial assistance to people who go into the profession of mental health work, right? It would pay back student loans. It would give them some.
It's a loan repayment program.
Yeah, encouraging more people to do this work.
You know, regarding mental health, we don't need our jails and our emergency rooms as the first line of care for mental health. And we've realized that as a state and put significant increases in funding toward provision of mental health. But we need the workforce to provide that care. And whether it's a professional counselor or a social worker or a psychologist, psychiatrist, those are not necessarily highly compensated positions, even at the doctoral level.
Right.
And often individuals are drawn to that profession because they'd like to work in that area, but they need that assistance to become practitioners. And so this is a loan repayment program that's stratified based upon the type of degree that one receives.
Chairman Crownover, that legislation will find a positive response in the House?
I would expect.
Yeah. That's what. So it's now it's passed the Senate,
and it's tied to regions of the state that have historically under representation of mental health providers.
Right. So it's trying to address specifically the problem of a shortage of docs.
Right. Their loan repayment, they'd have to be practicing in that area.
Chairman Crownover, another issue that I know Chairman SCHWERTNER has thought a lot about and has been talking about for a couple different sessions is nursing homes. The question of the 3 strikes rule and the degree to which we're going to try to take the bad actors offline. I think it's 3 times cited by dads within a 2-year period would qualify under the 3 strikes rule. Could you talk a little bit about nursing homes as an issue this session? Is this a focus of yours? I know it's a focus of Chairman SCHWERTNER's.
I think I'll probably be deferred.
You want to defer to the chairman?
Yes.
The nursing homes, and I'm really pleased to work with Chairwoman Crownover regarding infectious disease, and I know that's going through public health, but the issue of nursing homes goes through
Chairman Raymond.
Chairman
Raymond's committee.
But nursing homes, unfortunately, in the state of Texas, are ranked dead last in their care over the last 2 years.
Right.
We have over 1,100 nursing homes, and I believe that we need to continue to work at better regulating those nursing homes to make sure that they're providing the care to our parents and grandparents that reside in those nursing homes in a way that is at least free of abuse and neglect. And we need to get rid of those that are repeat bad actors, the worst of the worst. And so the bill that I authored that is now part of the DAD sunset bill, but also a standalone bill that both have passed the Senate, would have a mandatory revocation of their license for 3 repeat violations over a 24-month period, 3 separate independent level 4, highest level violations over a 24-month period. Yep. It certainly has caught the attention of the nursing home industry.
Yeah,
not
they
just
love
statewide,
this, I'm sure.
but nationwide.
Yeah.
But you know, the bottom line is they need to be doing their job, and they need to be taking care of those individuals that reside in nursing homes in a way that is appropriate, that we would expect our parents and grandparents to be taken care of.
And this lands, as you say, back through Chairman Raymond's committee.
That's correct.
Right, but you will work with Chairman Crownover on the infectious disease bill, and that was Senate Bill 538. That was also something that you were involved with. This expands authority for government and state health officials when at moments of infectious disease. We just actually had some suspected Ebola case, I think, in Dallas just last week, did we not? I think the result of it was that it turns out not to be, right? Can you talk about this as an issue? I mean, we kind of, you know, we have a short-term memory in this state and in this country. Ebola seems so last year. But, of course, there was all this attention to it, and obviously from the standpoint of giving our state and government officials the opportunity to do what they need to in a case like that, we've got to have some legislation to provide that authority.
Yeah, we are so over Ebola at this point, so that's a good thing. But there are other things that could be even worse, and sometimes you have to imagine your worst nightmare. And there does need to be an organized, statewide way to handle this. And it's not just a matter of some people having diseases. You have to think about it in kind of the worst case scenario, where American Airlines doesn't fly into the state anymore, where transportation is shut down, schools are closed. So it's not just a matter of public health. You can't separate something like that from the whole economic structure of the state. And that's why I applaud the work that Senator SCHWERTNER has done on this. Yep. And I think it's a tough issue. We're into civil liberties, but there are times where you have to be prepared and ready to step up with an organized plan.
Right. We're also, Chairman, into local control, except there are cases, as we've seen this session, where we think the state's got to step up and set some parameters and some guidelines, and this would be one of those cases.
Yes, sir. I'm honored to have Chairwoman Crownover sponsor that bill on the House side, but make no mistake, our country will face another infectious disease threat, in my opinion, sometime in our life. And
how did we do last time? What did you think about the state's response last time? Is this legislation in response to concerns about the way we dealt with it last time?
Yes, it is, absolutely. The governor's task force on infectious disease preparedness that Governor Perry put in place was a number of experts in the field of infectious disease, but also emergency preparedness. And we all saw, as citizens, some of the concerns and deficiencies up in Dallas regarding simple things such as disposal of infectious disease waste, medical waste transportation.
Yep.
How do we go about quarantining or isolating individuals suspected of infectious disease, but also that definitely have it inside the hospital?
Right.
Do we need, and the bill speaks to a number of those issues. It's the recommendations of the governor's task force, but it goes a step further. We had some interim hearings this last year regarding Ebola and infectious disease. And so it allows the governor to declare a state of infectious disease emergency when there's a clear threat that is not contained at the local level. It allows for the establishment of high containment treatment areas at UTMB and also one in Dallas. It handles things such as medical transportation. It allows for control orders, enforceable control orders to be instituted. It's a fairly substantial bill, but I think it can be a model for the rest of the country to look at regarding their preparedness. Because quite frankly, when it comes to infectious disease, something like Ebola, but even things like pandemic influenza that back in 1917 killed 50 million people, we need a statewide or nationwide approach to that serious of an issue.
Chairman.
I have been visited by a major city that said, you all don't need to do this, we've got it under control.
We've got this.
Yeah,
right,
we've got this. We've got it down. But when it crosses the county line, or it could happen in Colorado City. It could happen in San Saba. So those are small areas. So there's no saying that it's going to happen in Houston
and
or
they
Dallas.
may not have adequate resources, facilities to
right. So we need a comprehensive
plan in place.
Big picture on how we handle this.
Chairman SCHWERTNER alluded earlier to the sunset bills, the DFPS, come back to that in a second. You referred to the HHSC sunset bill, a little bit of a snafu in getting the HHSC sunset bill approved by the House 2 weeks ago, Chairman. Sent back to committee. There were a bunch of amendments put on related to abortion issues, kind of blew up there on the floor, points of order and all that. Now it's going to kind of get sent back to committee and then come back out. Do you think that the House, when they come back with this bill again, should come back with a clean bill with no amendments? Is there a way to avoid what happened last time happening again this time on that bill?
No, just in theory. We've had lots of talks, and probably we will have a bill next session that kind of addresses what a sunset bill should and should not do.
Right.
It's not respectful for all the hours that have gone into these sunset bills
right.
to then be able to have kind of free-for-all on the House floor.
Well, it became a Christmas tree with lots of ornaments by the end there, didn't it?
It doesn't make sense. It's
Yep.
not respectful. Any member can go to the Sunset Committee hearings.
Yep.
If you're not willing to put in the time at the beginning, I have trouble with you having a great idea at the very end.
So next session, you're going to deal with legislation related to what a sunset bill is and is not. But with regard to getting that bill back to the floor of the House this session, what do you think will happen? How's it going to come back? In what form or fashion?
I don't have a crystal ball.
You don't?
No.
Chairman SCHWERTNER, there are very few members of the Senate who are as pro-life as you. So I don't think the question is whether or not you support the amendments of the sort that were put on the House side, but you understand the challenge from a process standpoint of getting this bill through. Would you like to see that bill come back to the House floor clean?
The bill you were speaking of is the Department of State Health Services
right.
sunset bill.
Yes.
And we are going ahead and moving it on the Senate side now. We have basically passed out most of the other sunset bills off the Senate floor.
Right.
But we held back because DSHS was supposed to go first with Chairman Price, or Representative Price. But now that that bill has been kind of stuck in the House, we're going to go ahead and move the Senate version. These sunset bills are very important, but they are potentially Christmas trees in the sense that because their caption is so broad that you can attach a lot of different types of amendments
right.
that deal with that agency or that concern.
So they're too big to fail.
They're too big to pass sometimes.
Right, or it turns out maybe too big to pass.
But they have been well vetted through the Sunset process,
yep.
both by Sunset staff and then, of course, by the Sunset Commission, of which I served on, and then through the committee process. So we've heard lots of testimony, lots of input to these bills. We started down overall regarding the Sunset and the health agencies. The big one, the most important to me is the DFPS sunset bill, but the second one is the reorganization and realignment of the Health and Human Services Commission enterprise. Right. And that's a bill that Senator Nelson is authoring. I think is an important bill. We started that process in 2003 with 2292, House Bill 2292. And there are a lot of potential pluses and some concerns about further reorganization. And when change happens, people get nervous. But the realignment of the enterprise, I think, is appropriate to try to provide those services in a more efficient.
We're going to have a lunchtime conversation today about exactly what went wrong over contracting and other issues at HHSC. Mm-hmm. I know that has actually slowed some of the progress toward consolidation, has it not? There's people are concerned about what's going on inside the agency.
Sure. 85% of Medicaid recipients receive their benefits now through contractual obligations to MCOs and other providers. Right. And we as a state need to, and we have through various bills that have been authored, I think Senate Bill 20, I believe, is Senator Nelson's contracting bill.
Yeah.
But I need to be much more aware of how we go about procuring, negotiating, and then overseeing our contractual process.
Yep.
And be quite frank, we have not done as good a job as I would like. And these are huge dollars that go through some of these contracts. 21CT is relatively small fish compared to, from a dollar standpoint,
tip of the iceberg
compared to some of the MCO contracts.
Yeah, the reporting on
And
this has been been kind of alarming, Chairman Crownover, has it not, to discover all these contracting issues?
No, and you know, you look at the long term of, while I've been in office, we started talking about outsourcing, and we just thought outsourcing was probably the best idea that had come down the pike in a while. But you have to be able to manage the contract before you outsource, or you're going to lose your shirt. You know, you lose your shirt one way or lose your shirt another way. So I think that's kind of a sober moment that we have had.
Yeah.
That we're going to have to, we owe it to the taxpayers to get smarter, more efficient about how we do this.
Now on the DFPS, quickly, Chairman, before we go to questions from the audience, so my takeaways from your effort on this, SB 206, reducing paperwork and red tape, increasing the amount of time that DFPS staff get to spend with kids, with the people ultimately receiving services, reducing staff turnover, and increasing training of caseworkers. This seems like hard to argue with stuff, right? Not controversial stuff.
It is. I'm proud of the support I've received from both sides of the aisle regarding the DFPS sunset bill. It has been thoroughly vetted with stakeholders, and you know, the bottom line is one of our highest obligations and duties as a state is to make sure those children that need the help of the state and those families that need the help of the state get so in a timely and appropriate manner. And whether it's having caseworkers that we recruit and train and retain, that's a huge issue. CPS is going through a transformation, is the term we're using, regarding its policies and procedures and environment and culture.
Right.
And this all started through the sunset process with certain sunset management actions, but it's a lot of the codes and the statutes are being changed in this bill to allow DFPS to continue to enhance their operation. So I'm quite hopeful. I'm real proud of the Commissioner, Judge
It's been
Spisha.
a big priority for you.
It has been a huge priority. And unfortunately, in my Senate district, Colton Turner was one of the tragedies. And I've had a tragedy out in Rockdale, Texas. And there have been some other ones in Georgetown. 2 small children drowned at Lake Georgetown. Yeah, it's something the state, again, needs to fulfill its duty when it comes to protecting and providing and evaluating cases of misuse and abuse and taking care of those children and those families.
Chairman Crownover, before I go to the audience, I was begged by somebody before I came over here today, please ask Chairman Crownover whether she's going to allow medical marijuana to come up for a vote in committee. It's amazing what gets people's attention. What's your mood on medical marijuana as we sit here today?
Well, I think that's something that we need lots of input about. We need to watch what Colorado has done. We need to watch what California has done. I've talked with legislators that have quite an interesting story to tell that live in those states. But the hearing that we had was very compelling. And I think everybody in the room learned some things. I think it's something that we're going to be talking about and working on, but I think it needs a lot of time and attention.
So not on a fast track?
No. Not
on a fast track. All right. Agnes has a microphone. We're going to go to questions from the audience. If you have a question, please raise your hand. We'll be happy to call on you, and we'll take as many questions as time permit. Ma'am.
Hi, this is Grace Shemaine with the Texas League of Women Voters, and we support the Affordable Care Act and trying to get as many Texans covered as possible. Is there a plan, since nothing really has happened this session, to have an interim study where we figure out y'all have been talking about, well, we need to keep looking into this, we need to keep looking into that. Is there a plan to have a study to find out how we could help these people get insurance by next session?
I'll speak to that. We had it this last session regarding trying to isolate and classify who are the uninsured. And quite simply, expansion of Medicaid doesn't, in a complex state as Texas, doesn't solve that problem in its entirety. We have, again, a large population of undocumented immigrants that any expansion of Medicaid will not provide them coverage. We also have the issue of those that are above 400% of the federal poverty level that choose not to obtain health insurance as required by the law, by ACA. And then we have those that are short-term in between jobs that would also not be helped. But we'll continue to look at the issue of the uninsured. I think Texas needs its own solution to that problem. It is a unique state in a lot of ways, and a growing state, and one that I think can really be helped out with a flexible plan that utilizes the LQHC robust network and the community or county hospital network and our health-related institutions. But just blanket wholesale expansion of Medicaid is not, in my opinion, for the reasons I illustrated earlier, is not the correct way for Texas to approach this issue.
Will there be, to the questioner's point, any interim work, Chairman CROWNOVER, Chairman SCHWERTNER? Should there be any interim study between this and the next session, this session and next session?
We'll continue. Yes, it'll be part of the interim charges, I'm sure.
You think so, Chairman?
Yeah, our interim charges, to my mind, need to focus on that Healthy Texas 2030. So what does Healthy Texas look like? Does it use telemedicine? Does it use more quick care clinics?
Right.
Does it involve a medical home? Does it involve education? You know, if tobacco and obesity are the main thing, now I understand people have terrible diseases, and we are very aware of that. But statistically, if tobacco and obesity are our main problems, this is almost an education problem, not a healthcare problem as much.
Chairman?
Yes, just speaking of that, I absolutely wholeheartedly agree with what Chairwoman CROWNOVER is saying. Health, the predeterminants of health, 2/3 of it is your own personal lifestyle choices, what you smoke and eat and exercise, right. Lifestyle choices, whether or not you wear a seatbelt. Those things are very difficult to change by the provision of any insurance. And so health care and then also health care insurance doesn't necessarily mean access. And on the back end, what does it do to those individuals already on Medicaid?
Somehow my mind is turning to the reintroduction of deep fat fryers into the schools. Wondering if that's consistent with what you're saying, Chairman. Not your committee, right?
Those type of lifestyle choices are unfortunately ingrained by how we're brought up and also the environment that we're put in as we go through our life.
Yeah, Chairman. Before we take Chairman, you brought up telemedicine. We're going to have a panel later today over on this fight over telemedicine. In fact, I believe there was a lawsuit filed last week on this very topic. Are you bringing up telemedicine favorably as one possible arrow in the quiver of providing more access to the docs?
No, it's definitely. You know, right now we already take a picture and send it to the doctor, and it helps diagnose. So it would be crazy to think that we weren't going to use that as part of the equation. I grew up in a rural area that telemedicine could be a wonderful thing to access to specialists. And I do think we need almost a comprehensive look at how we can best let all of our practitioners, all of our healthcare workers work at the top of their license.
Yep.
And work together. That's something that's kind of been held back, that we're going to keep doing it the way we have always done it. But,
yep.
But this is a different world. We have information access that is
yep.
absolutely incredible. So to think that we're going to keep doing it the way we did it 20 years ago doesn't make much sense.
Chairman, are you favorable to this idea of telemedicine? In fact, the whole bunch of topics about access to medical professionals, we can get into scope of practice bills, which have been, you know, big in both last session and this.
Well, I actually, when I was in training at UTMB through the prison system, did some telemedicine as a resident regarding certain inmates that were far, far away.
Right.
Texas Tech has done some novel work and fairly expansive work in this in West Texas. So Texas is a big state and probably does need the advantages that theoretically are there regarding the use of telemedicine. There's always the concern of establishing a provider-patient relationship, and if you're just doing it, are you doing it with video or just the telephone? And with telephone, does it give you enough information to actually make a proper medical decision regarding that individual you're speaking to? If you have have upper respiratory tract infection type symptoms, is it really pneumonia? When do you actually tell them to go seek care? These are fairly significant issues regarding the standard of care and quality of care that individual could be receiving. So we got to be careful in regards to that.
Yeah, I wanted to put in the caveat that it's not just open the door and let anything go. But we heard some interesting testimony in committee how a critically ill child could stay at home with all the monitors that they could set up at home, and the doctor could be watching and maybe catch a problem before the parents would have noticed it if the child is being monitored carefully by technology. So I think there's some really exciting things out there. Of course, we don't want to just blow it open without being careful and thoughtful and deliberate.
Agnes, I think we have time for one more. This is it, and then we're going to let the chairman return to the Capitol as promised.
Thank you very much. Both of you used the same word, unsustainable, to describe Medicaid and Medicaid expansion, and was wondering if either of you could talk about the calculations that led to that opinion, and certainly in light of at the start of the session was $5 billion in tax cuts from both chambers, and whether that can factor into it as well.
Chairman?
Sure. On a national level, our federal budget is 40% deficit financed, and we have $18 trillion in debt. And the largest portions of our federal budget are the portions associated with health, whether it's Medicare, Medicaid, or the new health entitlement, the insurance subsidies, and obviously the VA system, and then Social Security. Those are the largest portions of our budget. And the deal that's been brokered is a certain ratio of provision of federal funds into perpetuity, a 90-10 match. I just don't believe that is something that is sustainable at a federal level long term as you see our economy and the future workforce, the aging baby boom generation coming of age, the diminished numbers of individuals actually in the workforce. So that's one big component. And on the state level, Medicaid now is 30% of our all funds budget. Back in the late 80s, it was 11%. It continues to push out other vital issues and concerns of the state, including infrastructure development, roads and schools and utilities, water infrastructure. So you have to prioritize those issues from a state legislative standpoint and take a pretty judicious and wary eye about where the federal government is and where it's going to be in the future before you do a handshake with the federal government regarding that program or any expansion of that program.
I think if you talk to congressmen, they will tell you that it is unsustainable. So how do we hitch our wagon to that horse that we know is not going to get us there? And that puts a lot of creativity and work and thinking of alternate plans that we need to do here at the state level. And reminding everyone that that money that comes from the federal government came actually out of your pocket, my pocket, and your pockets. So I hope that we will move towards a block grant where every state is able to do their very best and come up with the very best plans that fit their state, taking into consideration all the things that are going on just in Denton, Texas, where we have the FQHC and we have the nonprofit groups that are serving people actually better than just having great insurance. So it's a very yeasty time.
It is. You want to say the last word?
I remember last year, Evan, that Congressman Paul Ryan, chair of the House Budget Committee, was down in San Antonio, and you were speaking to him about Medicaid expansion, the 910 match, and he point blank said that that'd be one of the first things that we'd look at cutting that percentage if push came to shove.
If circumstances went
Right.
south, right?
So, you know, we had a great opportunity, and I really do applaud our congressional leaders and even President Obama to address the issue of access to care and attempts at affordability. But unfortunately, what we got there in 2010 was the product of probably a small group of people in a very small room that came up with something that did not fulfill the promises that were given and put forth to the American people of $2,500 off your premium, keep your plan, keep your doctor, insure 46 million more individuals, and bend the cost curve down. None of those promises to the people of our country have been fulfilled.
Well, it's a good transition into our next panel, which we'll have in a couple of minutes. We're going to talk a little bit more depth about the Affordable Care Act in Texas. Please, for now, thank Chairman CROWNOVER and Chairman SCHWERTNER for joining us today. We'll take a few-minute break, and then we'll come back with our next panel. Thanks very much.